Good morning, everyone. This is Mark Urken, and welcome to our Friday morning program. We have just an absolutely incredible lineup for one of the most popular features of this program, which is our tumor boards that we've been running now for 2 years. I am going to turn over to the program to the Master of Ceremonies, Dr. Mike Tuttle, who can help us with the introductions here.
Fantastic, Mark. Thanks very much. I'd like to welcome everybody. And what we'll do is we'll just go around the video screen here and have everybody sort of introduce with one sentence who they are. So if we can bring up everybody's pictures, we'll go in the order that I have. Dr. Symonds.
Hi, everyone. My name is Chris Symonds. I'm an endocrinologist at the University of Calgary at the Tom Baker Cancer Center.
Dr. Ghaznavi.
Hi, good morning, everyone. I'm Munir Ghesani. I'm Chief of Nuclear Medicine in Mount Sinai Health System.
Perfect. Sana.
Hi, everyone. I'm Sana Ghaznavi, and I'm an endocrinologist at the University of Calgary.
Dr. Wirth.
Good morning, everyone. I'm Lori Wirth. I'm a medical oncologist at Mass General Hospital in Boston.
Perfect. Dr. Krane.
Good morning, all. I'm Jeff Krane. I'm a head and neck cytopathologist at UCLA.
Dr. Liu.
Hi, everyone. I'm Jerry Liu. I'm a radiation oncologist with the Mount Sinai Healthcare System in New York City.
A little subtle, but Dr. Khalil, what might you happen to do?
Moosa Khalil. I'm a pathologist at the Hurthle Medical Center, University of Calgary, and I will be presenting the pathology on today's cases. Good morning, everyone.
Fantastic. And you've already met Dr. Urken. Dr. Urken, one sentence.
I am Mark Urken, head and neck surgeon at Mount Sinai Medical Center.
Awesome. I always wondered where he worked. Dr. Pasieka, can you introduce yourself and your team? And I think you've got 3 cases for us to discuss this morning. We'll turn it over to you.
Great, thank you. Janice Pasieka, I'm an endocrine surgeon here at the University of Calgary. So I am going to start.
Janice, while you're pulling up your slides, just put out a call to all the people in the audience to please feel free to send in your questions, comments, and we will do our best to get to them.
Super. So everybody, you can see my slides? Perfect. So thank you. I'm from the University of Calgary, and Chris and Sana and I are really pleased to be here to present. In the spirit of truth and reconciliation, I would like to take this opportunity to acknowledge that I have the privilege of working and playing on traditional territories of the Treaty 7 First Nations and the Métis Nations of Alberta, Region 3. For those that don't know where Calgary is, we sit at the foothills of the Canadian Rockies, and this is our cancer center and our hospital over here. This is obviously a summer shot as it is snowing outside as we speak. I think if anything that COVID did for us, it has, the positive has brought a Zoom platform, which I'm sure other centers have found the same thing, that this has really enhanced multidisciplinary tumor boards and tumor care. Instead of having to drive across the city to the cancer center once a month, our team is able to link in electronically. And these are the players that are consistently show up and are at our tumor board, but anybody is welcome. And you can see we have all of the various disciplines covered. No financial disclosures. I am an executive board member of TIRO, and I would encourage all of you to download this app. And I would also say that I have the patient's permission to present this case. We have 3 cases for you. The first one is on Hurthle cell carcinoma that's metastatic to the subcutaneous tissue. We have a follicular carcinoma with a rising thyroglobulin. And then we have a young man with metastatic papillary thyroid cancer with a very aggressive regional disease, but now we're questioning what to do with his metastatic disease. So this is the first case. This gentleman at the age of 38, his story started in 2011. He had a 6.5 centimeter solid thyroid nodule, and he was living in Edmonton at that time, and he underwent a right thyroid lobectomy. The final pathology came back as a follicular adenoma, and that was all that was done. You fast forward, he moves to Calgary, and in 2016, he is seeing a pulmonologist here in town because he has the diagnosis of pulmonary sarcoidosis. He's 43 years old, and this clinician astutely picks up a 1.5 centimeter subcutaneous nodule sitting just under the incision of his thyroidectomy. So this is just an ultrasound of it. You can see it was just in the subcutaneous tissue. A core biopsy is done, and it came back as a Hurthle cell carcinoma. That's when I got to see him, and proceeded getting the path reviewed, which Moosa will go into in just a minute. And then I proceeded to do a completion thyroidectomy and then excise the old incision as well as this subcutaneous nodule, which was then reported as widely invasive Hurthle cell carcinoma. So Moosa, if you want to, I will advance your slides for you. Just tell me when.
Sure, thank you. So the tumor was in the gross description of the original report over 6 centimeters. I didn't have the opportunity to see the gross of that tumor because it was done at outside institution, but this is a whole mount slide of one of the representative sections. And as you can see, it has a undulating pushing margin. Please move to the next slide. And it has a fibrous capsule that separates the tumor, which is towards the right, from the residual thyroid parenchyma, which is the upper left. Next, please. The tumor has a follicular architecture, and you can see a large follicle at the center almost of the screen with colloid in it. And then the cytomorphology, which you see in the insert on the right side, is oncocytic. By that, I mean large voluminous cells with granular oncocytic cytoplasm or eosinophilic cytoplasm, and round nuclei with prominent nucleoli. We used to call these Hurthle cells, but now we call them oncocytic follicular cells. So with that, that's an oncocytic follicular neoplasm. Next slide, please. In one of the sections that were submitted, and I have to say, not the entire capsule was submitted, or at least not clearly indicated in the gross description of the original report. You can see that the capsule of the separating the tumor to the right from the rest of the thyroid to the left is having a vein and an artery running parallel to that capsule. And within the vein, you can see a part of the tumor or a tumor embolus within that vein. Next, please. That tumor embolus was partially attached to the vessel wall in the upper right, and it is also covered by endothelium where you see the long arrows. Next, please. So that would be a vascular invasion. And with that, this tumor would be an encapsulated angioinvasive follicular oncocytic carcinoma or Hurthle cell carcinoma. Thyroglobulin was done as part of the workup of that case originally, and you can see that the tumor is staining positively in an equivalent manner to the normal thyroid tissue outside. I think that's the end of that part of the pathology.
Yeah, so this was then re-diagnosed as an encapsulated Hurthle cell or oncocytic tumor, 6.2 centimeters, no extrathyroidal extension. And so in February of 2017, the patient was given 30 millicuries. And I guess my first question, Mike, is that enough? I know these are considered intermediate, but is 30 enough for a oncocytic tumor with vascular invasion?
Yeah, Dr. Ghesani, let's go with you. So a couple of comments about Hurthle cell cancer in general and radioactive iodine responsiveness and PET scanning. How are you thinking about Hurthle cell cancer when it's coming to you as a nuclear medicine person?
So in general, you want to have as much molecular signature of the tumor as possible so that it can help you in the subsequent treatment planning. If there is any known site of disease, like in this patient's subcutaneous nodule, And if we were able to look at both iodine and FDG PET, it gives us the idea of what is the relevant presence of sodium iodide importers, which will be effective in terms of the treatment as opposed to dedifferentiation with FDG uptake. So that would be very beneficial. But in this particular case, 30 millicurie, I would think, was probably insufficient dose.
But what if I argued that 30 was just as insufficient as 150 because these
Absolutely.
cell cancers don't concentrate radioactive iodine, right?
Right, right. Which is why I started off by mentioning that, ideally it would be nice to have that molecular signature up front so you can decide whether you to give higher than 30 or not to give anything at all.
Yeah. Janice and then Lori. Janice, this subcutaneous nodule, where was this nodule?
So this nodule, this one was just underneath the actual incision in his neck. And so, question was the tumor broached and is this seeding? But the difference was that in the operative report, there was no evidence or any mention that they got into the tumor, but it was right underneath the incision. So when I excise this, I excise the incision as well.
Let me do Mark and then Lori. Mark, we often see either a poorly differentiated cancer or a Hurthle cell cancer with these subcutaneous nodules right around the scar somewhere, underneath where you guys were operating. But there's never a note that says we ruptured this stuff, we spilled it, we had it everywhere. They're often these kind of encapsulated. So the question is this seeding from the time of the operation or is this a metastasis? Any idea?
Yeah, I think it's really intriguing, and I can't say that I'm going to be able to give you that much insight on what the pathophysiology is. I think certainly with that degree of vascular invasion that was highlighted, I got to believe that that's probably the greater likelihood rather than that this was spilling of tumor.
Jeff?
Yeah, I just wanted to weigh in. There was a nice paper done by the group at Hopkins a few years back that showed, especially with these Hurthle cell carcinomas, often these kind of rounded deposits that we see in soft tissue, that if you go back and look at them closely and use vascular markers, that the majority of them, do represent, venous deposits, not always easily recognizable just on routine histology.
And would make sense because these are usually angioinvasive, and that's the piece to it. Lori, you see a ton of Hurthle cell cancers, and they go weird places. Do you see them in the skin and other places?
Generally, no.
Yeah.
I think unless they are, very poorly differentiated, and then they kind of can turn up anywhere. But no, generally not. It's funny, because Hurthle cell carcinomas generally don't spread to lymph nodes, in the regional lymph nodes, but you can see other nodal disease elsewhere. You can see bone mets in these patients, lung mets. I certainly have a bad feeling about this guy.
I agree. Dr. Liu, anytime we see thyroid cancer in soft tissue or in other deposits, we're always thinking, is there a role for external beam? It sounds like in this one, Dr. Pasieka got a nice, complete resection, but are you thinking you're going to have any part of this upfront treatment where we are here?
Given the patient's age, despite the Hurthle cell histology, I think most of us are hesitant to give external beam radiation when there's a complete resection, even though there are subcutaneous nodules here. But to the point about this histology perhaps not being iodine avid, even at a higher dose, does bring to mind maybe the utility of radiation, either now or subsequent.
Jeff, he mentioned the age. I mean, I'm used to seeing Hurthle cell cancer in 50 and 60-year-olds. You occasionally see it in 20 and 30-year-olds. Does it look the same to you, Jeff? Is it any different? Does it ring any bells?
Yeah, I have to say, morphologically, I don't feel like I see, anything particularly distinctive based on range, age range. Yeah.
Okay. All right. So Janice, so at our place, we would have probably given this guy 100 and apologized for it, although there would have been some argument to use 30 sort of as high dose diagnostic scanning. So you'd have been in the ballgame. So let's keep going.
Yeah.
Hey, Mike,
Yeah,
can I just ask? Yeah, let me just ask you a quick question and direct this to Munir. And to anyone else, is there anyone who would advocate giving a low dose whole body, doing a whole body scan prior to the resection, just to settle the question? Is this at all trapping iodine?
Yeah, so if there's a possibility of putting the patient on a low iodine diet, and not only at that point, we can document the presence of activity in the lesion, but that will also help in the treatment planning, because as Mike mentioned, 30 millicurie may be too much or too little, depending on, these Hurthle cell tumors that are notoriously not radioiodine avid. If there is a way to document their uptake. So in a case like this, not only we would consider doing the radioiodine scan, but I would even propose that an FDG PET upfront might be helpful. If there are any, knowing the histology that we just saw, it's a high likelihood that the patient probably may have distant disease as well. And then FDG PET will be able to delineate that.
Right. So in his particular,
sorry, Mike, but can you do that? He had a whole lobe of his thyroid in, right? So he only had a lobectomy. So we didn't go with a scan first because we needed to do the completion thyroidectomy, I thought.
Agree totally, Janice. So,
but in terms of the FDG PET, it can actually help you to see if there was any distant disease in that case.
But Mark's point is good, because in somebody that's had total thyroidectomy before, I think it is wise to do a diagnostic scan, even if you're going to surgically resect those lymph nodes, so that we have an idea about whether they're RAI avid or not.
Right.
If they're negative, it doesn't necessarily mean they can't concentrate radioactive iodine, but it gives you a little feel for the lesional dosimetry. One other question before we move on, Lori. Apparently you're a fan of molecular testing on some of these tumors. You were worried about this guy. Would you go ahead and send molecular testing on him? And if it's a Hurthle cell, are you going to find anything that's helpful?
So yes, and no. As you know, Mike, with Hurthle cell cancers, what we now understand is that there are frequently mutations in the mitochondrial DNA that are not druggable. We also often see widespread loss of heterozygosity in these cancers that we think also is another driver alteration, also not targetable. We rarely find things that are potentially druggable, like a BRAF V600E mutation or gene fusions. If I saw a Hurthle cell with say a NTRK fusion, I would ask the pathologist to go back and tell me, is it really a Hurthle cell? I think the right answer is only if you expect that the patient's going to need systemic therapy should you do molecular diagnostics. But we're trying to do molecular diagnostics as much as possible in these more worrisome cancers, so that we have the information when we need it to make treatment decisions, and then also so that we can continue to learn as much as possible.
Yeah, and there was a second question that asked, could we use the molecular testing to decide radioactive iodine? Where everybody's working on that right now. Like the BRAF V600Es are less likely to concentrate radioactive iodine, but it's not zero. Maybe 10% of them do. The RAS are more likely. So we use it as sort of modifying factors, but you can't use it as a yes or no. Janice, we got to be done at 9. You want to go?
Yeah, exactly. So we'll just go ahead. So this was his, he got 30. I just want to remind you that he had a pulmonary sarcoidosis. So we confirmed that even biologically by doing a bronch and biopsying some of these lesions. The story then continues. So 17 months after his completion thyroidectomy, his unstimulated thyroid globulin was the same as his stimulated thyroid globulin. And now he had a 1.2 centimeter nodule in his sternal notch. It was Hurthle cell on fine needle aspiration. I then saw him in September, so 2 months later, and on my ultrasound, it had grown, as well as his thyroglobulin had increased. So we did just what everybody was talking about. We tried to figure out, does it take up radioactive iodine? We did a PET, we did an I-123, and is stimulated when we did the PET, thyroglobulin was 16. For time's sake, we then had to go chasing down a whole bunch of incidentalomas picked up on his PET scan and things that I'll say proved to be not contributory. So here's his PET that definitely takes it up with no disease elsewhere and nothing on his I-123 scan. So then in July, so it took us a while, so 29 months after his completion thyroidectomy, I go back in and now I'm finding two nodules. This is they're remote. They're in this sort of in level 7 area, but in the subcutaneous tissue. So down into underneath his manubrium. And you can see they had also grown in size. And you can also see that just before doing it, our thyroglobulin level was elevated. So this is just a graphic showing you, this is at the beginning when I first met him, this was a stimulated thyroglobulin. And then this is our other stimulated thyroglobulin. He gets this second lesion excised and boom, his thyroglobulin goes undetectable and remains that way. And it was 0.8 in July 2020. So he gets anatomical imaging as part of his follow-up. There's nothing there except he still has these nodules in his chest that we think are sarcoidosis. And then lo and behold, March, 31 months after his second nodule, a third nodule. And again, Hurthle cell, stimulated thyroglobulin has now gone up and we do a PET and it is PET avid. But I want you to note in a short period of time, it had actually grown. So the question here, third time around, it's in the subcutaneous tissue. Now it's out by the supraclavicular region. Do we just take this out again? Do we take it out and they give radioactive iodine, RT? Those are our questions that we posed before I tell you what we actually did.
Great case. Jeff, as you watch these Hurthle cell cancers, you know, we've seen these, they have a 2 or 3 year gap in between and they grow back locally. In the well-differentiated tumors, you can see them sort of gradually transition to more poorly differentiated. Do you see that in the Hurthles or do they all just look the same every time they come back?
Well, I don't want to give spoilers, but yes, we certainly can see them progress in terms of their morphology. Unfortunately, very unpredictable.
And what are the kind of things that you see that I when you put on the report that should flag me as this is becoming more aggressive? What are the type of things you describe I should know about, Jeff?
Well, certainly, you know, when we're talking about poorly differentiated thyroid carcinomas, increased mitotic activity or necrosis are total red flags for us. Probably subtler things that we might start worrying about. But these are really very soft and not diagnostic. Would just be some, you know, changes in the morphology with more atypia, higher nuclear cytoplasmic ratios, that kind of thing. But those really are not totally predictive.
Lori, before I come to Mark and Jerry about the local control, any other staging you want to do? There was a question about should we do a brain MRI? Should we do, because right now we're all focused on the neck. They've done PET scans. We're about to think about some maybe aggressive local stuff. For other staging purposes, anything else we should think about, Lori?
So I think, you know, in general, probably not. I think that we don't do enough brain MRIs in patients with aggressive thyroid cancer. However, I don't know that I've ever seen an isolated brain metastasis when there's never been other metastasis. When we see patients with advanced DTC that's metastatic, I do now do a baseline MRI. What we've seen in the studies that we've done in these patients is that there's about a 10% rate of patients with brain metastases. So I think that it's been an underappreciated phenomenon.
Agree. I missed those, I think, for years before I started putting folks on your trials. And it's that exact same group, like multiple Mets, multiple bone Mets, that you find them up there. Mark and Jerry, how are you guys going to deal with this? I mean, he's young, so we've tried to avoid external beam radiation as long as we can. But, you know, how many times are you going to go back in there and try to clean this guy out, Mark? How are you thinking about where you are right now?
Well, you know, I think what's obviously worrisome is that while these appear to be local regional recurrences, that he's going to pop up something that's distant along the way. But the local regional problem is becoming a significant problem for him. And so I would be thinking about wide resection of this and then follow up with external beam.
Jerry, what are you thinking? I mean, does Dr. Urken really need to do another wide resection on my brother for this? Or why don't you just fix this for me? Because, surgery's failed about 3 times. I'm not really interested in doing that again. Is there any logic of just radiating?
Putting me on the spot here of the evils of radiation, but certainly I do believe, as everyone has experienced, local control surgery or combined surgery and adjuvant therapy totally trumps a radiation modality for thyroid cancers. Trying to give local control with radiation alone, we'd be going to doses of 70 gray, absolutely dooming this patient to long-term late effects. So in this setting, I'd wait for Mark to take great care of the patient and then follow up with radiation. Just to kind of backtrack a bit, I'm not sure if that chart was all stimulated thyroglobulin, but that rapid rise in these repeated kind of focal regional recurrences in the same site of disease, I would have brought up the possibility of radiation at that point in the 2019 resection.
When you think about it. Hey, Jerry, a lot of times when you guys talk about radiation, I hear you guys say chemorads or radiation therapy. So assuming Janice gets a complete gross resection and you're doing basically adjuvant external beam radiation, is it external beam radiation alone or external beam radiation with some chemo as a radiation sensitizer? What would you normally do?
It depends on the findings and whether or not we can get a R0 or R1 resection, or if there's gross disease left behind. If there's multiple areas of, say, soft tissue invasion with questionable margins, R1 resection, then maybe we could consider concurrent systemic therapy. Or if there's obviously gross disease left behind, certainly we would consider concurrent systemic therapy.
Okay, perfect. All right, Janice.
Yeah, so that's his sort of time frame. You can see it's like every 30 months. And then, of course, what hit was COVID. And so in May, he was supposed to get this excised because our plan was a wide local excision skin graft and maybe hold off on the radiation, but it got postponed. It then starts to grow. His thyroglobulin starts to grow. He's supposed to have it in September. We get a 4th wave. All surgeries are canceled. So he gets booked in November when we ramp back up, and he says, this has gotten bigger. So I CT'd him just before. So this is August when it was 3 months later, it's now almost 4. So we can see this accelerated growth. And so when we went to excise it, I could feel the nodules. They were all sitting out here, but then I felt this sort of thickness of his skin, and we just sort of went big, go big or go home. And we took out a large piece because I couldn't tell if there wasn't something underneath. He gets a temporary collagen graft, and then 2 weeks later, he gets a split skin, thickness skin graft. And then I think Moosa will go quickly through the pathology and have to wrap this case up
as fast as I can. So this is just from the 2018 resection, just to give you an idea about what we saw then. And the point is, there was a differentiated Hurthle cell carcinoma sitting in the subcutaneous tissue. This is the skin here at the top on the right. And there is no scar tissue or foreign body reaction surrounding that nodule, to the point of Dr. Krane, that there is no evidence that this is a recurrence at the field of a previous surgery. It looks like a clean field. Next, please. And here you can see the cytomorphology is very similar to the primary that I showed you earlier. It's oncocytic and it has macrofollicular architecture with a lot of colloid. Now we fast forward to 2021, and here you can see a nodule. You don't see a lot of colloid in it, but again, sitting in a clean field of subcutaneous tissue, the epidermis is at the top. Next, please. And now we don't see the macrofollicular architecture with the abundance of colloid. There are some trabecular areas and there are some microfollicular areas coming up in the next slide, where you can see these microfollicles with a little colloid in them, but there were areas which are just trabecular with no colloid at all. Next, please. The striking thing here is the increased mitotic activity. And I counted 13 mitosis in 10 high-power fields. In this one field, which is 400x, you can see 3 mitoses here. Next, please. And just to convince everybody that these are mitoses, I did the phosphorestone H3, which highlights those mitotic figures. So these are not apoptotic cells or degenerated cells. And this 400x field, you can see 5 of them. Next, please. The Ki-67 index was about 10.5%. Next, please. And the thyroglobulin, it was attenuated compared to the previous, which you can see here. We can go to the next slide, please. This is the primary tumor to the left, and this is the recurrence. In 2021, you can see the reduction in the amount of thyroglobulin staining to some areas have that dot-like appearance. Next, please. There's also vascular invasion, again, to confirm that point that was made that these are probably due to vascular spread. Next, please. So that would be, for me, by the memorial criteria, is a poorly differentiated carcinoma now, oncocytic type, because of the increased mitosis, even though I did not see necrosis. Perhaps if one would apply the other system, which is the Turing criteria, because of the presence of follicular architecture, maybe this may not qualify for the poorly differentiated, but those criteria, they do. And the tumor deposit measures 4.1 centimeter, and the resection margin was uninvolved. Thank you.
Man, difficult case. While we switch over, let's switch over, Chris, to the second case. Sana, let me put you on the spot. So you've got a complete gross resection. He's going to get his external beam radiation. This guy is going to get distant mets at some point in the future. You'll probably control his neck for several years with the surgery and the radiation. How are you going to do his follow-up for surveillance, Sana? I mean, there's no answer here, but what are you thinking?
So one of the things that I think is interesting about Hurthle cells in general is Moosa showed us the loss of TG, on the path, but he actually is a good TG producer. So actually that's always been reliable in terms of the TG correlating with the tumor burden. I think that's one. The second thing is obviously I'm looking for distant metastases, and I do think I'm actually the endocrinologist on this case now. That wasn't previously, but took over his care about 2 years ago. And so I think, for example, getting now a baseline MRI brain, I'm thinking more along those lines of being a bit more comprehensive with the staging. And yeah, so those are my thoughts.
I often talk about taking your endocrine hat off and putting your oncologist hat on, right? This is not somebody you follow with an ultrasound. This is cross-sectional imaging, keeping a close eye, make sure we don't have an early recurrence, because I doubt he goes 3 years without something else, right? His pace is probably going to pick up. Great case, challenging case. Thanks, Janice. All right, Chris, what do we got?
Great, thanks very much. Dr. Tuttle tells me you might call this case a case of where's Waldo. So this is, I'm going to try to go through this fairly expeditiously given time. Anesthesiologists or surgeons always complain about waiting for anesthesiologists. This is kind of the opposite way around, although I'm not an anesthesiologist. I've had to wait for a surgeon to finish here. So this is a 60-year-old lady, who presented initially to Dr. Pasieka back in 2017. She actually had a long-standing history of what she called a goiter dating back to 1996, so quite some time. She had gradual progressive enlargement. She was reluctant to have surgery. She had several biopsies, which were reported clearly as benign Bethesda 2. She had no relevant comorbidities, no risk factors for thyroid cancer. Eventually, given the size, she did consent for surgery. She was thus taken to the operating room by Dr. Pasieka now 4 years ago. Complete resection was achieved. There was a large retroposterior component. The pathology, which I'm not going to review, but will, because I'm interested in some of the follow-up, was felt to be a widely invasive follicular thyroid cancer. There was extensive vascular invasion. The maximal diameter of the tumor was 6.2 centimeters. There was no nodes involved. There was no extrathyroidal extension. There was some molecular diagnostics done on this test, and there was felt to be a TERT promoter mutation. This patient staged a T3A tumor, stage 2. The recurrence risk was graded to be high. Post-operatively, the major problem has been ongoing and progressive elevation in thyroglobulin. We gave her over time the first radioactive iodine treatment with 100 millicuries, just so simply fairly significant central neck uptake, only in keeping with the remnant. Following along, we then actually ended up giving her a second dose a year later, which showed just very faint central neck uptake, really nothing anywhere else. And then we have done several FDG PETs on her. The first one, again, you know, findings that all of us might see sometimes. It's very hard to know the significance of it. There's a 0.3 centimeter focus in the right thyroid bed, very small pulmonary nodule, notice with very mild FDG avidity. Difficult to know the relevance of this with no FDG uptake anywhere else. I just show everyone here a table. These are all mostly completely TGs with suppressed TSHs. There are a couple of stimulated on the right, but I just like to show you the progression over a 3.5-year period from a TG of 8.6 up into the 300 range, with a thyroglobulin doubling time of almost 8 months towards the end. This is just representing it graphically, showing a log scale on the left and the gross values on the right. And you can see both the predicted and the actual values follow this algorithm actually quite nicely. So as things go on, again, once again, we are hunting for Waldo. Another PET scan was repeated twice in 2020, showed this same 0.3 centimeter nodule. Throughout this time, the patient remained 100% asymptomatic. Apart from me making her anxious for doing all these tests, she was functioning, feeling well, no bone pain, really nothing. We did a number of other tests, which I've listed there: ultrasound, CT neck, chest, nuclear medicine bone scan, I-123 scan. Really nothing. I have taken her to tumor board at least 3 times. There was question about, are we missing an occult bone metastasis? Finally, we seem to have cropped up with an answer here. This is a recent FDG PET just from last November. There are now 5 pulmonary nodules. The one we've been watching is larger. The SUV, as I'll show you in a slide in a minute, is markedly increased. There are 3 new nodules, and one that they're saying in retrospect was only 2 millimeters before is now 4 millimeters. But once again, there's no lesions anywhere else. So again, is there a disconnect between the level of thyroglobulin and what we're finding on both our anatomic and functional imaging? This is just a couple of screenshots from showing the representative right upper lobe nodule. And you can just see on the top half of this is the recent FDG PET with the SUV of 25. And then that same lesion a year previously at 2.66. And then again, this is just the new nodule shown on the capture image from the CT PET, showing some of the differences there. So I'm going to wrap this up and leave up for you these 4 questions that I have. And I guess the first one is the one that I just alluded to, was comments on the discrepancy between the progressive and marked thyroglobulin rise and the challenges we've had in both functional and anatomic localization.
All right, Dr. Urken, this thyroglobulin is getting up in the 200s and 300s. Where you know, the patients are going nuts because they're still trying to find them. What are you going to tell this person? She's 60 years old, so she's young by our criteria. What are you going to tell her is going on here?
Well, she clearly has disease, and through all of these studies trying to find it, and you know, I do think the question becomes, how often do you image? How what are you going to do to try to stem the tide and make her give her some comfort here? This is not a surgical problem. I think you've imaged the neck, and I think this really obviously lies in the range of medical oncology and nuclear medicine.
Dr. Ghesani, the limit of resolution, like on the PET scan, you know, has she had small volume lung mets the last 3 or 4 years and we just couldn't find it? Where do you start picking up lung things on the PET scan that you believe is real?
Yeah, so it depends on the generation of the scanners. Now, our most recent generation scanners have better resolution because they are digital detectors. So we are able to sometimes pick up the activity in the nodules less than 7 millimeter, which was initially the benchmark that was considered for when the lung cancer application of FDG PET-CT was approved. Now the resolution is improved, but equally important is the notion of the blooming, which is that if there is significantly high number of mitochondria in a given setting, then even though the nodule may be small, there's usually a blooming effect such that the other pixels around the nodule start to take up some of the residual signal, and they, to your eyes, look larger than actual size of the nodule. And I think looking back in this particular patient, knowing that ultimately the SUV went up to 22.9, also explains that there's probably a very high expression of mitochondria. And that would also imply the fact that the next question about the thyroglobulin we'll discuss, but there probably is a significantly high amount of thyroglobulin being produced by these aggressive nodules.
I mean, these are always challenging. My kids had the book called Where's Waldo, and you're always chasing where these are. So I often tell these patients, you could have lots of small volume pulmonary metastasis, because remember, the chest CT can't see less than 3 or 4 millimeters. So I think the disconnect you have here, if you did a biopsy, she's going to have lots of multifocal disease on the lungs that you're not seeing. I think that's where her volume's coming from. So multiple small volumes that are very good TG producers. That's probably what you have here. Bone mets happen over and over, that the thyroglobulins go up in the hundreds before you can find these small bone mets, because for whatever reason, bone mets get this really out of proportion thyroglobulin for very, very small disease. The other place I always look is the skull and the base of the skull. I've seen over and over PET scans miss disease at the base of the skull because where the brain takes up. So if you wouldn't have been seeing stuff in the lungs, I go look at the base of the skull and the calvarium, because that's usually a little bit outside. The other place I see this is in the kidney. You'll occasionally see a kidney met from a follicular thyroid cancer, and it gets ignored because everybody calls it cystic lesions and nodules in the kidneys. So I think about small volume lung metastasis that take several years to do. I tell patients they're below the radar screen at 4 millimeters, and next year they'll say there's new ones. They're not new, they're just getting big enough to see. Base of skull, and the kidneys. So I think you're there. Lori, good Lord, we've been watching this poor lady, and she's coming back every 6 months. And you know, when do we do something here?
Yeah, so that's a really important question, and a question that I think is difficult to answer. And I think the best approach is to really individualize the pulling the trigger for the individual patients and what's important to them, as well as what their disease is doing. But you know, she has low volume disease that's not rapidly progressive. She doesn't have a lesion that's even as big as 1 centimeter in size. So she would not meet criteria to enter any of the clinical trials for iodine refractory disease. So I would say sit tight, you know, and you know, we'll continue to monitor the disease. And try to minimize the anxiety. It's also a good time to talk to patients about the idea of prehabilitation. Likely an MKI is in her future, and there are, we do think that patients who have good healthy lifestyles, get plenty of exercise, even weight-bearing exercise, probably tolerate the MKIs better. So we're beginning to try to work that into our period of disease monitoring for these patients. So we don't have a randomized trial that tells us that people will live longer if they start earlier versus later. but we have actually looked at the SELECT trial with lenvatinib that randomized patients to lenvatinib or placebo, and then the patients that received placebo crossed over to receive lenvatinib when they had disease progression. So it's difficult to really look for overall survival benefit because of that crossover. But nonetheless, we've looked at several different aspects of the data and post-hoc analyses. And it does seem that people do derive a longer, better, deeper clinical benefit when the drug is started earlier versus later. And there was an analysis that was done taking a look at patients with lung mets, and patients who had lung mets who were randomized to lenvatinib or placebo had a longer survival when they were randomized initially to lenvatinib, despite the fact that 89% of the patients crossed over and received lenvatinib at progression. So with lung mets, when patients have lung mets as small as 1 centimeter in size, they actually have an overall survival benefit when they start lenvatinib earlier. So that's one of the aspects of that I think is important to discuss with patients. Then, of course, you also have to discuss the impact on quality of life from side effects from therapy, which everybody has to expect to experience some side effects. And so there's a balance, and the formula for which is most important to a patient depends on the individual patient.
Dr. Ghesani, we're in that space with this patient of probable structural progression, not rapid or not big enough to go with TKIs yet. She's fairly unresponsive to radioactive iodine, 2 doses of 100 millicurie. Is there any space in here for these redifferentiation trials, or trying to make, and this is probably going to be a RAS-like tumor, right? It's a follicular tumor. It's probably going to be RAS-like. It's got the TERT mutation. Would you be thinking about redifferentiation or trying to use radioactive iodine in here?
Yes, in fact, we have done so. As you know, we have collaborations between Memorial and Mount Sinai, and we have either used the I-124 for the dosimetry planning or I-123 scan with the gamma camera imaging. And these patients actually do benefit after redifferentiation. So this patient could be a candidate for that.
Yeah. So in our place, we would do full molecular testing to get some better feel for what it is. And then one of our medical oncologists would probably put them on a redifferentiation agent for about a month and repeat the scan to see if we can get some uptake. There's a couple of other questions that are tangential that I'll have you do. Lori, role for zoledronic acid in people with bone metastasis. Do we talk about it? Do you really do it? Where are you on that? And then I'll come back to Dr. Ghesani, something about a FAPI PET scan. I never heard of that. You can tell me about that. Lori first.
So yeah, there is a role, I think, for bone modifying agents in patients with bone metastases to reduce the sequelae of bone metastases. There are good studies that have been done in multiple tumor types and studies that have enrolled thyroid cancer patients. In general, we do start Zometa. One thing that I do is I don't do monthly Zometa, but do every 3-month Zometa, expecting that the patients are going to be on Zometa for a while. And then also, we're really meticulous in terms of the dental evaluation and dental hygiene because of patients with xerostomia related to their radioactive iodine. And I think I tend to use Zometa as the drug of choice rather than denosumab. But I think that, the denosumab is also an option.
Very good. Munir?
Yeah, so FAPI is a very promising new agent on the horizon. It has been studied extensively in Europe and Australia. And we now have discussions of having access to FAPI for multiple cancer applications, including thyroid. And it's a fibroblast activation protein. And it actually has more diverse localization in multiple tumor types. And also the target to background is considerably higher. We just had a review of hepatocellular carcinoma and cholangiocarcinoma, and there we also found extensively higher amount of FAPI uptake relative to traditional agents such as FDG, or in the case of liver, gallium-68. So this could potentially be an application, but here we already have FDG uptake localized. And as you said, Mike, there are probably multiple more underlying nodules. So if we did a FAPI and compared it to FDG, it's very likely that higher tumor volume could be detected with FAPI in the lungs, and that can explain the rise of thyroglobulin values.
Yeah. So, I mean, I think it's a great case. I think we would pretty much all follow it along the same way. At least for me, in terms of deciding when to do something, I use 5 things: size of the metastasis, location, rate of change, are they symptomatic or likely to get symptomatic, and then patient preference. So those are the 5 things that I think about: size, location, rate of change, symptoms, and patient preference, because that'll be your next decision point in somewhere here. If there was a role for a redifferentiation scan, we would probably at least be talking to the patient about that in this intermediate space between just completely watching and moving to kinase inhibitor therapy. Okay, very good. All right, let's go up to the last case. Dr. Ghaznavi, what do you got?
Okay, you guys, we have a hard stop at the end of the hour, so I will do my best. I think I'm going to skip through some of the images and things. So let's, one sec. There we go. Okay, so my case is of a 33-year-old gentleman who has just a past history of primary hypothyroidism. He's a Catholic missionary, he's married, and they don't have children. That'll become relevant in a sec here. So he was in Ontario in spring of 2021 and basically noticed some increased work of breathing at that time, was worked up and found to have obstructive sleep apnea and started on CPAP. He then moved to Alberta, where Calgary is, in the summer of 2021, had a new GP who astutely noted that there was some fullness in his neck. So got things rolling with a neck ultrasound, which showed multinodular goiter, but also some clinical lymph nodes in the neck. A biopsy of the isthmic nodule and right lateral lymph node were positive for papillary thyroid cancer. And so he was referred to one of our surgeons, Dr. Chanarana, who's on the call here today. So this is the part that I'm probably not going to do justice to, so I will go through quickly. But essentially what we're dealing with is a tumor where there's a question of gross invasion into surrounding structures, specifically the trachea and the esophagus. There's also, this next image here shows that there is some partial encasement of the right common carotid by the lymph nodes. So there's a question of whether complete resection is going to be achievable. Okay, so I will stop there for a sec here, Dr. T, and what other investigations would people want?
So Mark, what are you thinking? I mean, a 33-year-old guy with tumor invading larynx, I mean, this is weird, odd. So what are you thinking here about this case?
Yeah, this is not behaving like a pure papillary. This looks to be certainly an aggressive variant. Obviously, I worry about the potential for this to become a systemic problem. But the bigger issue is the local regional control here. The fact that he's got bilateral cord dysfunction is just so extraordinarily unusual. But the image of this encasing the carotid, also extraordinary in the primary setting. Under the circumstances, there is not much to do for this gentleman that's going to be saving his functional larynx. And so you've got to be thinking more of an aggressive resection if you're going to get local regional control. And that's going to likely involve a laryngectomy.
Jerry, what do you think? I mean, you're going to end up being part of this story here somewhere in all likelihood. And when we're looking at early on, how are you thinking we're going to use external beam radiation in this?
I mean, we're hoping we get a great resection of all disease, a gross total resection, and then followed by iodine therapy, and holding off on external beam. But just looking at these factors of tracheal, possibly lower down invasion, this carotid encasement, I'm definitely waiting in the wings.
So Mark, I mean, we're thinking about taking out trachea and taking out larynx in a 33-year-old. I mean, how much are you willing to do if it's surgically resectable to, I guess if this is squamous cell carcinoma, it'd be a different story, but I mean, this is a bad thyroid cancer in a young person. We're really going to have to think about some of these more aggressive surgeries, right?
Yeah, I don't think there's, with both cords being affected here, the ability to, you got to assume that both nerves are being invaded. And the ability to salvage this, it would be one thing if one cord was out, but with both being out, there's just nothing that you can offer that's not going to be, that's going to include saving his larynx.
Because local control is life-saving for this guy, right? I mean, you don't want to be a nice guy now and this end up biting you in the butt in 2 years or 3 years. This is a real oncology local control issue. What do we need to do to get this under control? All right, Sana, keep going.
Okay, so as Dr. Urken mentioned, there's impaired mobility of the vocal cords bilaterally. We did a CT chest that just showed some small indeterminate pulmonary nodules and a sclerotic T3 vertebral body lesion. Followed that up with a bone scan, and although the T3 lesion didn't light up, we did see uptake in the multiple ribs and right ilium, some areas where we would expect thyroid cancer to metastasize, and he's asymptomatic from those. These are just the bone scan images. So again, the surgery, this is a la endocrinology, and this is what I got out of it. Obviously, it's a complex surgery. So total thyroidectomy was undertaken, a bilateral neck dissection, a laryngopharyngectomy with a radial forearm flap. Essentially, what an endocrinologist is taking from this is this was an extensive surgery. It's going to leave the patient with lifelong morbidity, obviously. It was necessary, and you're going to be hard-pressed to have a surgeon want to go back after this type of operation, right? So the intraoperative findings, there was gross invasion into multiple surrounding structures, including the bilateral recurrent laryngeal nerve, a lot of disease in the right and left lateral neck, and the right IJ and vagus had to be resected. There was some unresectable disease, right parapharyngeal node, really high up, so it was not reachable. And so we've left that behind. And then left-sided disease was all resected, which is really what made the surgery, resectable. Post-operatively, he got admitted to the hospital to just manage a fistula, and it was managed well and healed at the bedside just with wound care. So that is the surgery in a nutshell.
Okay, let's stop right there and let's talk about the management here. So Janice, for a simple endocrinologist, what did you take out and what did you leave behind for me?
It was our ENT plastics team that did this. It was really a tour de force. And so everything's taken out, and he has one little node that's left behind, but basically his whole larynx, the thyroid cancer, and as much lymph node disease as one could obtain.
Okay, Mark and then Jerry, you get a minute apiece. Mark, management here, watch, external beam radiation, radioactive iodine, 1 minute, go.
Yeah, I think that you'd certainly like to have some idea if there's anything, any molecular signature that might be useful in the future. I worry about that retropharyngeal node that could not be reached, and I think given this gentleman's biology of his tumor, I think that's going to be a problem down the road. I don't think you get away without giving radiation therapy. He's at great risk for local regional failure.
Jerry?
Yeah, I would agree. I think the sequencing in general, you would proceed with RAI and then followed by external beam. I'm also very worried about that parapharyngeal node. I think another slide showed it was due to carotid attachment. We know that there was attempt at randomized trials for patients getting surgery, RAI, plus or minus radiation therapy, but they just cannot accrue. And the results are just not really definable. But a retrospective series looking at these really poor pathologic features do show to benefit for radiation. So I would advocate for just a total combined approach for this young man. Local control, I agree, is life-saving for him.
Jerry, it's not fair to exactly ask you fields without seeing everything, but I mean, what kind of fields are you thinking about doing? I mean, this is not going to be a focal thing. You're going to do, how much are you going to radiate?
Let's say what I might spare. Okay, so perhaps the left neck we could spare. I think that was well resected. There was the adenopathy on that side wasn't that bad, but the right side, from skull base all the way down to the aortic arch, including the central neck, the thyroid bed. I think that should all be covered, and likely with a boost to the parapharyngeal node, depending on the results of the RAI.
Yeah, and just we're about to finish up. Just so the audience knows, the path did show papillary thyroid cancer 9 centimeters, both sides, grossly invasive. So I guess it's still theoretically possible that this could concentrate some radioactive iodine. So I think I would give external beam radiation up front to consolidate the surgical control, even though I'd love to give radioactive iodine before external beam radiation. And this one, I'd be nervous to wait. And then when he got to swallowing better, 3-6 months down the road, probably radioactive iodine. Dr. Ghesani, last thing, 30 seconds.
Yeah, so because it is such a complex case, the multimodality treatment is going to be very effective because there is not much guideline in terms of handling cases like these unusual cases in the book. So we have to go for as many modalities as can be applicable to give him some chance of disease-free survival in a reasonable time.
Perfect. We're right up against the hour, team. Janice and team, thank you so much. These were great cases. We're as stuck on them as you are, and we wish the patients the best. Have a great day, and thanks for being part of it. Mark, any last thing before we sign?
No, thanks to everybody, and please come back next week. We will have another great program, but all hats off to the group out in Calgary. Thanks so much for putting this all together.
Thanks, guys.
Bye, everyone. Be well.
Thanks, everyone. Bye, everyone.
Thank you.